So I want to thank for the opportunity of presenting our work here. The time is short, so I will keep it brief. And if you have any questions or remarks afterwards, please feel free to reach out to me or Bart, my colleague from the team. So I'll present here on behalf of the Dutch team working on SPIRIT. And I will present the 3 papers that we've published until now. And we're still working on some new research and hope to continue working in European and Dutch and even international collaboration. So the first paper is about adapting and supplementing the existing protocol. So the existing protocol from the US, SPIRIT. The second paper was about the impact and aftercare of this intervention. And the third one about emotion regulation by the patients. So to introduce, I will keep this really short because of the time. We know from the other presentations on this conference that meaning, spirituality and religion are important in healthcare, that the need has been seen by patients, and that it can be found to be a struggle and a resource for patients, which is important to both include within interventions. So in 2022, Dr. David Rosmarin came to the Netherlands to present the SPIRIT protocol. And at that time, the need for conversation was growing within psychiatry. To talk about it, 40 to 50, 75% of the Dutch patients wished to incorporate MSR within their therapy, but experienced little room for it. So that's why the importance of SPIRIT was felt and a Dutch team was created. So I will quickly first introduce SPIRIT, what it is, and then highlight the insights from our papers. So SPIRIT stands for Spiritual Psychotherapy for Inpatient, Residential and Intensive Treatment. The SPIRIT is a CBT-based protocol, which means that it gives structure, and the meaning is discussed on the basis of beliefs, which can be seen as the cognitive, and activities, the behavioral part. It's used to shape emotional experience and gives a structured yet modular and flexible protocol for psychiatry. It's specifically designed for acute psychiatry because at the time of development, there were little to none interventions for severe disorders, and none known where therapists were included in, like non-clinician-led psychotherapies within acute psychiatry. So there was a gap there that could be filled. The aim is to discuss the relationship of MSR and well-being, both for clinicians and for patients, because they both have the lack of tools. So SPIRIT offers a concrete tool there to discuss the topic. It identifies helpful concepts, but also acknowledges that it can be a source of struggle. The SPIRIT group therapy is a 30 to 60 minute group therapy. It can be used standalone, but also multiple times. It consists of 2 parts. First, there's a group discussion based on the question, how does MSR affect my mental health? And how do my mental health challenges affect my outlook on life? So both ways. And then after that, the clinician, together with the group, decide which handout they will work on. Which brings me to our first paper, the cultural adaptation of SPIRIT. So as said, it was made by Dr. Rosmarin together with his team, and we culturally adapted it to the Dutch context. For this, we used participatory action research design, which means that you test the knowledge in action. So you use direct experience and collaborative analysis with different stakeholders to create or develop knowledge. So we did this together with a project group, advisory board of several professors, and a multidisciplinary team of professionals and patients in an iterative process. So the results of this first paper, let me see, is firstly that patients appreciated the space to discuss MSR. They highlighted the need for broader themes to also discuss responsibility, loneliness, and grief. Both caregivers and spiritual counselors recommended a broader range of perspectives on life and to develop creative ways to work with the handouts so that the patient input could be taken along because the context can be very different, the patients can be very different, and when it's an open protocol with creative possibilities to work with it, you can really adapt it to the situation. So patients generally were not negative, they were mostly positive, but highlighted these additions. Then also on the variation, there was a resistance to the lengthy texts and more need for patient input, as I said. So based on that, there were more handouts added for the Dutch adaptation. So the main changes actually included to include more outlooks on life. So for example, in the fourth handout of Sacred Verses, we included several outlooks: humanism, Judaism and Christianity, Buddhism and Taoism, Islam and Hinduism. And also in the first three handouts, we included more quotes that were more broad, or for example, we supplemented encouragements to be inspired by art or by spaces in nature. Next to that, in handout 8, for example, we added the meditation part. While not everyone is praying based on their religion or spirituality. The second addition that was important was these important themes that the patient asks for. So in handout 5, for example, we included responsibility. Then we added 6 about loneliness and 9 about grief. And thirdly, we added some visual and applicable content. So for example, in handout 7, no, I'm saying it wrong. In handout 10, Letting Go and Forgiveness, we included some insights from the work of Edith Eva Eger to make it applicable, and the discussion really focused on some beliefs. And we added some a word cloud, for example, in one of the handouts. So furthermore, when it was adapted, we found 4 institutions to work with the protocol. 2 of them were regional and secular, and 2 of them were national and Christian. Within these institutions, we had 12 trained clinicians and more than 250 patients. And as you see, there are now more institutions involved for further research. So we did 180 evaluation forms, 19 client interviews, 8 clinician interviews, and 2 focus groups. Due to the time, I will not go in depth about these, but they were used for the second 2 papers that I will present. So the first one is about impact and aftercare. So this study investigated whether participation in SPIRIT is experienced as supportive for recovery, whether MSR, both in the private networks as well as in therapy, is effectively integrated and contributes to coping and the experience of meaning. And thirdly, whether SPIRIT influences broader determinants such as psychological, social, and environmental factors, and thereby fostering long-term development of positive coping. That went too quick. Yes. So The results showed that the role of spirit, that it created greater awareness of personal meaning, spirituality, and worldview. For some patients, that meant that they had a subtle change in attitude or interest and experienced increased openness or renewed engagement and a sense of gentleness towards themselves or towards others. And an experience of recognition or affirmation during the therapy by having a discussion and seeing other people struggle also was found to be helpful. So this increased awareness and behavioral change was found to be meaningful change, and also highlighted the need to keep the insights afterwards. So a structured follow-up is needed. However, some barriers remain. So caregivers can have limited awareness or the preparedness to discuss it, or patients feel that there's a taboo around it, which this combination of barriers suggests that the clinician should be the one to create this opportunity to talk about MSR within therapy and to actively address it. So then to our third paper, let's see, I have 2 minutes more, right? So the third paper is about emotion regulation. So for this paper, we looked into how spirit as a psychotherapy addressed meaning in life, spirituality, and religion, and how it influenced the emotional regulation or the emotion regulation. So some of the patients indicated that experiencing and expressing the emotions was very important to them, and that they felt that it was all right within the context. However, others mentioned that it was difficult to show their own emotions, that they felt discomfort with their own, but also with others' emotions, that it was too strong. And sometimes that the space to show their emotions should be facilitated more. However, mostly the conclusion could be that it's heavy, but very beneficial, as most of the patients mentioned. Secondly, about the regulation processes, we used theory as a basis for this to code the data on. So from the expressive and behavioral, we see that both verbal and non-verbal expression was present, and that the problem-solving actions showed. So, for example, patients wanted to work on positive goals, or they wanted to change their relation to loved ones and do something for them. For the second one, patients reflected on their systems, views, and experiences of MSR and emotions surrounding it. The social and interpersonal. So this was often valued because they saw recognitions of others. It felt like they could have an open conversation, which also opened this possibility outside of therapy for some of the patients. And this safe environment gave them a feeling of connectedness. We also saw that if the caregiver is disclosing their own emotions or like talk about their emotions about it, that this also adds to the feeling of connectedness. And then for the avoidance and suppression, this was actually hard to see, because we think, or we know that patients who would avoid this topic would probably withdraw or not come to the session. So it was hard to find it in the data, but regularly the patients showed to be okay with the evoked emotions, and distress tolerance took place. This was, So for the mechanisms behind it, firstly, patients mentioned that situating their suffering within a broader existential perspective or a spiritual narrative reduced their emotional chaos and promoted coherence within their story about themselves and about life. Secondly, the discussion of the patients helped them to view their experiences more compassionately from a transcendent vantage point, creating more cognitive distance from the distress. On the third level, acceptance and tolerance of painful internal states increased, often triggered by the discussions about MSR, about the struggles and the suffering and the questions about life. This acceptance and tolerance about the struggles helped the patients to experience their emotions without escalation. Fourthly, the connectedness and social belonging, both with others in the group, but also with the larger, with something larger than themselves or a God, fostering this feeling of support from the larger group or from the God or larger self. And as I said, the disclosure of group leaders also seemed to strengthen this. Comfort and safety was reported, which seemed to be grounded in the perceived presence of a transcendent being or the transcendent, reducing fear and emotional reactivity. So after this, I only have a conclusion slide, so I will stick to this slide for a bit more as the results are interesting. So the narrative integration, the sixth level, sixth point, unfolded as patients wove difficult life events into a more coherent life story, which reduced their fragmentation about their life story and offered a sense of continuity. And when the participants reframed their situation in the light of a future possibility with hope and spiritual trust, or signs of that it all had meaning, it provided a motivational energy and also an energy for moments of despair. Then the last point of control and self-efficacy, this was implicitly increased. So engaging in the discussion about MSR and about existential themes reduced avoidance, and it fostered a sense of self-efficacy. However, this was not explicitly linked to the MSR part of SPIRIT, so it suggests that the therapy goes beyond meaning-making and facilitates contemplative processes. We, as seen in the studies, we see that it's of course different for the different institutions. There's a slight difference in data, which is based of course on the context of the acute psychiatry, but also on the role of the therapist. So we can conclude that SPIRIT CBT has a meaningful impact on patients' lives, highlighting a clear need for a structured follow-up, both privately but also in treatment context, to consolidate the insights and support coping with emotions. So yeah, an open dialogue on existential themes is needed in therapy, and SPIRIT creates a good opportunity for that. And the culturally adapted version is well received in the Netherlands, and we hope to disseminate it also to different countries in international collaboration. So thank you very much for your attention. And yes, the questions will come after.